Is Qunfeng Dong. I'm a professor at Loyola University Medical School. My presentation is based on a publication with my colleague Dr. Xiang Gao, who is an assistant professor at Loyola Medical School. Back to March and April 2020, clinicians have already noticed that most patients hospitalized with COVID have some sort of underlying medical conditions. This is a New York Times report back in April 2020. And that New York Times report was talking about this published paper in JAMA based on hospitalized patients in New York City area. On the right is a table from this paper. It's a typical table 1 or table 2 in a medical research paper summarizing the patient information. When we are working on this project, CDC also released the report. The table on the right also summarizes the number of hospitalized patients with different comorbidities. So what I will present is based on these two published data sets. Again, we do not have access to the underlying patient level data. All we had is those two summary tables that we have to work with. The question we are interested is what is the hospitalization risk for people with comorbidity infected by the SARS-CoV-2 virus? Ideally, we can analyze how many of those people with some medical conditions who are infected become hospitalized. Based on those numbers, we can calculate absolute risk or other types of measurements. But it's complicated for COVID because we don't really know how many infected people are not hospitalized, since many non-hospitalized people have very mild symptoms or even asymptomatic, and they do not even know if they were infected. So the traditional way to estimate the risk, either absolute risk, relative risk, or odds ratio, won't work without this missing or unreliable information. What we do have are data for hospitalized patients. Since we do still have the hospitalized data, can we do something with it to infer the hospitalization risk? So that's our research question. And in the next several slides, I will explain how we developed a Bayesian approach for this problem. In order to understand our method, I need to introduce some notations. Let's say the size of a general population is N-pop. There are three types of people in this population. First, people who do not have any underlying medical conditions, we call them healthy people, indicated by green dots. Second, people who have the comorbidity of interest, say diabetes, indicated by the red dots. And third, people who have other types of comorbidity but not diabetes, indicated by the blue dots. We use kappa C to represent the prevalence of a comorbidity, say diabetes, in this general population. Then, the expected number of people with diabetes is kappa C times N-pop. Then, if the probability of a viral infection for those people is rho C, the expected number of infected diabetic people is rho C times kappa C times N-pop. Finally, if the probability of hospitalization for those people are tau C, this term is actually the absolute risk for those people to be hospitalized. Then the expected number of infected diabetic people who are hospitalized should be tau C times rho C times kappa C times N-pop. We can use the same logic to infer the expected number of hospitalized COVID patients who do not have any underlying medical conditions. In this case, kappa H represents the prevalence of people without any underlying medical conditions in this general population. Rho H represents the probability of viral infection for those people. Tau H represents hospitalization risk for those people. Then the expected number of infected people without any comorbidity who are hospitalized should be tau H times rho H times kappa H times npop. The last category we want to infer is the expected number of hospitalized COVID patients who have other types of underlying medical conditions. In this case, instead of introducing another parameter kappa, 1 minus kappa H minus kappa C actually represents the prevalence of people with other types of medical condition in this general population. Then, the rest of the logic is the same as in the previous two slides, and we can infer the expected number of infected people with other types of comorbidities who are hospitalized should be tau O times rho O times 1 minus kappa H minus kappa C times npop. Okay, I promise we're almost done with those notations. We just need two more parameters, theta H and theta C. Theta H represents the expected prevalence of hospitalized COVID patients without any comorbidity, and theta C represents the expected percentage of hospitalized COVID patients with the comorbidity of interest, for example, diabetes. Then, using the expected number of the three categories of hospitalized patients I introduced in the previous slides, we can express theta H and theta C with these two equations, which are essentially the expected number of hospitalized patients in each category divided by the total expected number of hospitalized patients. Then we can see that the population size npop can be cancelled from both the numerators and the denominators in these two equations. And we can also cancel those rows if we make one biological assumption. That is, people have the same probability of being infected by the virus. We'll talk about this assumption during the discussion later. Then we can derive the simple term for tau C divided by tau H. If you recall, tau C represents the absolute risk of hospitalization for COVID patients with a comorbidity of interest, for example, diabetes. Tau H represents the absolute risk of hospitalization for COVID patients without any medical conditions. Their ratio, called risk ratio, represents the elevated risk of hospitalization for COVID patients with a comorbidity compared to the patients without any comorbidity. What is interesting is that the risk ratio can be expressed by a simple algebraic relationship between kappa and the theta that we derived. Then we can put everything in a Bayesian framework. We can model the mathematical relationship between unknown thetas and the observed number of patients in each category using a multinomial distribution. We can model the prior distribution of these thetas as a non-informative Dirichlet distribution. Couples can be modeled as informative beta distributions based on epidemiological studies. So there are two types of inputs required for our method. The first is the number of hospitalized COVID patients and their comorbidity information, which is the two tables I showed in the previous slides as well as here. The second input is the prevalence of comorbidity and healthy in the general population, which we had to dig out from public health resources. Then we can use the method of moments to convert those prevalence information into the parameters for kappas in our Bayesian models. Then we use a Bayesian sampling technique called Markov chain Monte Carlo MCMC to obtain the posterior distribution of the risk ratio for each comorbidity. We have applied to our method to those two large data sets I mentioned earlier, one from CDC, one from the New York regional hospitals. Both data sets gave similar results. For example, the red curve represents the posterior distribution for the risk ratio for people with cardiovascular disease. Both data sets consistently show that cardiovascular disease carry the highest hospitalization risk for COVID patients. The median value is more than sixfold. You can look at detailed results from our paper. So honestly, we don't know if our predictions are correct, because a gold standard would be a prospective study to follow a cohort and then analyze their clinical outcome, which we don't have. But there are reports indicating that pre-existing cardiovascular disease seems to be linked with the worst outcome for COVID patients. So at least our results do seem reasonable. Finally, I want to offer two discussion points. First, our current results are based on one biological assumption that people in the general population can be infected by the virus with similar probability. This is based on the rationale that nobody is particularly immune to the SARS-CoV-2 virus since it's a newly emerged virus to the human population. However, our framework can be updated by incorporating appropriate informative prior distribution to reflect the differential degrees of the chance of infection. Second, we were unable to analyze joint comorbidity. For example, the risk for people who have both diabetes and obesity, since we only have summary data. But our framework can be extended if we have access to the patient level raw data.